Come in.
Hello, Mr. Renhel. My name is Jacob Frankenberg. I'm a registered nurse. I'm going to be performing a health history exam on you today. I understand you're in here for just a routine checkup. We're going to be checking your thorax, your lungs. We're going to be listening to those as well as palpating your chest. We're going to be listening to your heart, and I'm going to be checking your peripheral vascular system to make sure everything's working in good order. Let's start off with a little history of these areas. Mr. JR, do you recall any significant medical problems in any of these areas?
No, I've never experienced any problem with my breathing or any chest pains. I consider myself pretty active, like in sports and all that.
Okay. Well, that's good to hear. Staying active is very important. Part of maintaining health, actually. Do you recall your most recent health exam?
No, I think it was back in 2013. I mean, I know that I should be cutting on the salty and the greasy food.
Okay. What type of job do you currently hold?
It was for a police officer position.
Okay. Well, thank you for the work you do to protect the public. Do you recall if there were any negative findings at that time?
No.
Okay. How would you describe your diet? Like what you eat on a daily basis, or what do you consume?
I mean, I know. I know that I need to cut on all salty and greasy food.
Yes, we could all improve in that area. Do you smoke?
No.
Anybody in your household smoke?
No.
Okay. Does anyone in your family have any heart or lung conditions that you're aware of?
No.
Okay. All right. First, I'll start off by examining your thorax and lungs. Could you please remove your shirt for me?
Yes.
All right. First, Mr. JR, I'll be observing your lips, your ears here, your fingernails, your toes. We're just looking to see color, if there's any discoloration, which could be a sign of the amount of oxygen that your body's receiving. Or in your fingers, if there's any kind of clubbing, there's, more round or defined at that area, that could be also a sign of your body's chronically not getting enough oxygen. At this point, you want to observe the patient's nose, see if there's any nasal flaring. You want to see their mouth to see if they're mouth breathing. Are they breathing through their nose? You want to observe the neck, the trachea area, and note if it's midline. The patient has a tracheostomy or anything like that. First, we're going to have the patient perform a Shamrock test. Sir, can you please put your index fingers together like this? Okay. And if you could point that towards the camera. You should be able to see a hole, a gap in there. The client should be able to see through it. That would be a negative Shamrock sign. A positive one would be, identification the patient does have some clubbing there in the nails. So if you put them together like this, you would be able to see through. All right. Now we're also going to discuss the landmarks of the body. You want to go ahead and stand up and face the camera here for us? Okay. And we're going to go through. First, we're going to look here, and we can notice the sternal notch here, which is an indentation here. We're going to notice the clavicles. We're looking for symmetry on both sides. Noting the ribs here. Okay. You have the membrane. You have the sternum here coming down. You have the xiphoid process here, which you should be able to feel here. Okay. You can also note the coastal angle of the ribs here. It should be less than 90 degrees here. With this gentleman, you might have to just press in a little bit so we can feel that area. Okay. The sternum is made up of three parts here: the membrane, the body, which they're both. If you come here from the area here and you slowly move down that first little notch, you can feel that's the angle of Louis. Then you go all the way down and you'll feel the xiphoid process right here as well. And everybody, of course, like I said, we have two clavicles, 12 sets of ribs. Seven of these ribs are connected directly to the sternum. And you have two sets of floating ribs, also known as, and three sets of false ribs, and then two sets of floating ribs. False ribs meaning that they're just connected to the cartilage that extends from here, from the sternum. Okay. And then the two scapula are gonna be located in between. When your patient turns around, looking at the back, you have the two scapula, which will be located within the second intercostal space ribs, and the eighth ribs here. Okay, there's 12 thoracic vertebrae which connect all 12 ribs, and you can start from counting them at T1. So you're going to come down here. It's going to be the first prominent one. You can feel it. And then the one right below that would be T1. So you're going to slowly just drag your finger down, and you can count all the way down to 12. And that would be the thoracic area there. Also, while standing, you want to note their posture, their shoulder height, the clavicle and subclavicle levels here. Are they even? Have the client bend over. Sir, can you please bend over? Okay, you're just going to notice the curvature of the spine. If one shoulder is going more than the other one, you want to see the line here. You can fill the line here and see if it's straight. If it's outward, if there's excessive outward, that'd be scoliosis. No, that would be kyphosis if it's hunched out up here towards the top. Scoliosis would be spine would be curved to either one of the sides. Lordosis would be on the lower end. The spine would be outward, also known as sway back. Okay, so you can come back. There's a Sprengels deformity, and that's where which one of the scapula is much lower than the other scapula. Wing scapula. Can you please put your arms out, straight out? Okay, and put one down. Okay, and you would notice the scalpel right here would be pushed out. It would stick out. Okay, so please turn back around. Okay, lungs, you have two lungs, of course. The right side here being consisting of 3 lobes, here on the left side 2 lobes, and they fit nicely here in the rib cage. You have the pharynx up here, the larynx. Okay, the trachea that extends down into the bronchial that goes into both the left and the right lung. The diaphragm here, which is the cavity located here, helps divide the thoracic and abdominal cavities, which lies between the 8th and the 10th rib cage. And we'll check later on the location of the diaphragm and how much it expands. Some important landmarks to know will be the mid-sternal line. Okay, which will be straight down here. Okay, we'll have the mid-clavicular line, which you're going to pretty much come here to the mid area of the clavicle, and it will be straight down here. Okay, the anterior axillary line, which is going to come pretty much right here off the end of the clavicle, straight to the bone. It's going to be a straight line down here, imaginary line. Okay, also some more prominent lines that we'll have as well is you'll have the anti-axillary line, which will be right here, your mid-axillary line, and your post-axillary line. Okay. You have your vertebral line, and then right here at the apex, you're going to have your scapular line, straight down here. Okay, so please turn on one more time. When you have the patient, you're going to auscultate, palpate, and percuss, always following a sequence for efficiency, which is going to start off in a 1 to 12 position. It's going to be 1, 2, 3, 4, 5, 6, 7, 8, 9, coming over here, 10, 11, and 12. So we'll try to follow that same path each time when we go. Okay. Again, we'll start by inspecting the area. We're observing the skin in the thorax area for any lesions. Is there hair, the amount, the color, the locations of the hair? Is there, like I said, lesions, freckles, acne, any bruising, rashes, scars from trauma in the past? It may, from past surgeries, it can lead us into asking, further deeper questions. Maybe that the patient might have left out in the health history. They might have forgot of an old surgery many years ago. Or also strea, which would be your stretch marks. Also, we're going to note any edema, any generalized edema. Checking the texture here. The texture should be the same without. the warmth. Okay, so warmth should be the same throughout. And we're gonna check any the bony cage using it from the side and back, including costal angles. Like I said here, which should be less than 90 degrees. We're looking at the size, shape, symmetry of everything in the chest and the thorax. You can measure the chest line here, and you want to go through the nipple. Can you please raise up your hand, sir? Okay. Okay. And you want to go up here at the nipple line. And we're at 119 centimeters. And always have your pen and paper ready. All right. And you want to notice, is the chest barreled? Is the chest caved in, which would be pectus excavatum, or is the pectus out, which would be pectus carnatum? Okay, we want to observe the patient's respirations, looking at them, how many or how full. You want to check the respirations for a minute, which we're going to do right now. Okay, which we got 18, which is a normal finding. You also want to notice the depth, the type, the pattern. Are there any influences such as anxiety, activity, pain, drugs? The respiration should be 12 to 20 a minute. Greater than 20 would be tachypnea. Less than 12 would be bradypnea. The types of breathing, there's different types of breathing, which would be Cheney strokes, which would be a periodic breathing with apnea. Biats, which is irregular, unpredictable, maybe shallow or deep, and may stop for short periods. Kuzmas, deep and maybe labored, maybe fast or slow. Also, we're going to check a respiratory excursion. We're going to have the client turn around. Okay. And what you want to do is you want to get right here just below the scapula. You're going to have your hands, you're going to slowly push in. All right, now, sir, can you take a deep breath for me? Okay. And you're going to see your hands pull apart there. All right. Go ahead and breathe normal. Okay. Another deep breath. Okay. And then back to normal again. Okay. So you want to notice that how many centimeters. It should expand about 3 to 5 centimeters. Here in this case, it was approximately 4 centimeters. So we're going to write that down. All right. Now we're also going to palpate. So like I said, here in the front, like we did earlier, we're palpating. We're seeing if there's any lesions, any, bumps, anything that is abnormal or should not be there. To the thorax area. Okay. And the same thing in the back here. Okay. And noting right in between each intercostal space. Okay, and first we're going to feel between those and note any tenderness or discomfort. If there is discomfort there, of course, we don't want to percuss that area, so we'll note to skip that area. Okay, so like I said, we're going to go through our areas. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Okay, sir, did you feel any discomfort, sir, while I was pressing on any of these areas?
No.
Okay. All right, next we're going to do percussion. You're going to explain to the client first, sir, I'm going to be tapping your back. You want to make sure the head is midline with the arms crossed. Can you please cross your arms, sir? Okay. Okay. All right, sir. Okay, sir, if you just please breathe in and out through your mouth. All right, you're going to start from this side here. And you should hear a resonant sound. Anything dull would be, you may be over the bone. You want to avoid going too much into the scapula. That would be a sign you just get a dull sound over that. So we want to hit the lung fields, which would be closer here. See, we get a duller sound here. We're going to do the same here in the front. So resonant sound is going to be a medium, loud, low pitch. It's a normal sound. Hyper resonant is going to be a louder pitch. And here we're starting at the first intercostal space. Down. All right. Hyper resonant sound would be a louder, lower pitch found in maybe a child's lung or maybe someone with emphysema. Timpani, which is a loud, high pitch. You would notice here over the stomach area. If you're hitting that area, it's usually sound of intestine. A dull would be like a soft, high pitch, more dense organs such as a liver. A flat would be a very soft, high pitch over, thigh muscles, bone, or tumor. Earlier we looked at diaphragmatic excursion and side-to-side expansion. Now we will be looking into the bottom area here. Please turn around, sir. Okay, and what we're going to do is we're going to have the patient exhale, and we're going to tap until we hear that dull area, and then we're going to mark that with a pin. So can you please exhale? Okay, so there we had a dull sign, so we're going to come slightly back up here. We're going to mark that spot there. All right, sir, can you go ahead and take a deep breath for me now? Okay, so now we're back at a dull here. All right. And this should be normally 3 to 6 centimeters. In this case here, we were at 3.5. So this was on the right side. And we're going to do the same thing here on the left side right now. So on the right side, we were at 3.5 centimeters. Okay, so now we're going to do the same thing on this other side. All right, sir, can you please exhale? Okay, so this is the last spot we hear it. All right, sir, now can you please take in a deep breath? All right, so at that point we heard a dull sound here. And we're going to measure that one as well. And 3.5 centimeters. So they were both on this, both sides were the same, and that's a normal finding. That's what we want to find. That it's the same on both sides. That's showing the lung expansion is the same on both sides, which we want. We're going to check for tenderness at the costovertebral angle. Again, if tender on palpation, we don't want to percuss the area. There are two methods, direct and indirect. Okay, so we're going to do an indirect method here. Okay. and then we're going to do a direct method. Do you feel any discomfort there, sir? Okay. All right, sir. Can you please turn around? And let me get here on this side of you. There you go. All right, now we're going to listen to breath sounds. Make sure to listen through 1 to 2 complete respirations by asking the client to breathe in and out through their mouth. So someone asks you if you can please just continue to breathe in and out through your mouth normally, just like how you do. You want to note the time on inspiration, expiration, the different types of breath sounds. There's vesicular, tracheal, bronchovesicular, adventitious. So vesicular sounds are heard over, most of the normal lung and reflects passage of air into the alveoli, like a soft swishy noise, which you'll find more in these areas here. Okay. Tracheal are known as bronchial or tubular, and they're heard over the trachea, right here in this area from here, which are okay at that location, but not if they're heard over the lung area fields here. Is a high-pitched sound that results from turbulence or high through the trachea or bronchial. Bronchovesicular are a mixture of both normally heard and over the bronchial on each side of the sternum at the first and second intercostal spaces. So pretty much right here in this area here, we should still be able to hear those bronchioles. And in the backside, for the scapula near the the thoracic T4 and T5. So pretty much right here in this area here. It has a breezier, softer sound than the trachea. Okay. So like I said, the bronchial here, trachea in this area, and vesicular all through these areas here. Adventitious breath sounds are non-normal breath sounds. So right now when I start listening, they can include crackles, which are also known as rails, which is produced by movement of air through fluid-filled tissue. This can come in 3 forms. It could be fine, medium, or coarse. It could also have wheezing. Sometimes just looking at the patient, you can hear the wheezing, and you don't even need to use the stethoscope. In this case, I don't audibly hear any wheezing without the stethoscope, but like I said, right now we'll listen and we'll know in more depth. Wheezing, which occurs when the air passes through small airways they may be narrowed by thick exudate or edematous membranes in the bronchioles. Bronchi is another adventitious lung sound, which may be due to mucus accumulation, a tumor, or muscular spasms in the trachea. And there's also pleural friction rub, which is caused by an inflamed pleural surfaces. On this one, you can have a patient hold his breath and listen. If you still hear it, it may not be a lung. It may be pericardial that you're hearing. So to distinguish the two, you can ask them to hear it. Also, there's stridor, which is a high-pitched piercing sound, and that one can definitely, usually be heard without a stethoscope. That results from a high obstruction of the respiratory tree, the trachea, the larynx up here. Okay, so we're going to go ahead and listen through the lung sounds there. Okay. So we're going to start up here high. Make sure it's clicked on the right one, the diaphragm here. Okay, and we're going to do the same thing on the back side. Okay. And remind you're listening through one whole breath sound. Okay. And also, you can assess tactile fremitus using the palmar or the ulnar aspect of your hand. You can use one or both hands, and you're just gonna have the patient repeat 99 or blue moon. So, sir, when I tell you to say 99, you're gonna say 99. Okay. Say 99.
99. 99.
Okay. Again.
99. 99.
Okay, so what you should feel is a vibration resonance, and it should get decreased as you go away. If it gets louder, or if you can't feel that vibration, then there may be something wrong with that. And we can go ahead and do that here in the front as well. Okay, sir?
99. 99. 99. 99.
Okay, so that was a normal finding there. There's 3 different methods. There's the bronchophony, which the whispered, what is it, the proterquili, and the egophony. So also we're gonna do the same thing, but now we're gonna listen. Okay, so this is the vocal. Okay, sir, can you just please say 99?
99. 99. 99. 99. 99. 99. 99. 99.
Okay, so it should start to fade away as you're going down. In this case, it did. Okay, now you can also do a whispered, and you shouldn't be able to hear it. So I'm just going to ask you if you can just please whisper 99. Okay, and you can look at their lips and see their lips moving to know that they are continuing to do it. Just continue to whisper 99. Okay, and we weren't able to hear that. Another one that we can do is the egophony. We're going to ask the patient to say e, and it should not sound like ah when you're listening to the lung lobes. All right, sir. Can you please say e?
E. 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 E.
Okay. So no difficulties there. Sorry, can you please turn around? Also, the whole time you're interacting with the client, you want to note their breath, which could be a key indicator of some problems. You may smell alcohol in their breath, a sweet, fruity, which could be a sign of diabetic ketoacidosis or starvation ketosis, a fishy smell, fishy stale smell, which may be uremia, ammonia-like, which also may be a uremia or ammonia, a foul fuculent smell, which may be an intestinal obstruction or diverticulum, a foul putrid smell, which may be nasal or sinus problems. Halitosis, when you're smelling the breath, may be a sign of tonsillitis, gingivitis, oral infection, respiratory infections, or gastroesophageal reflux. The halitosis, we want to make sure there's no infections there in the gum area, because that can, lead a direct path to our heart and our peripheral vascular system. Okay, now we're going to go ahead and move on to the heart and peripheral vascular. Again, we're viewing the body as a whole. We're observing the eyelids, the auricles, the nose, the mouth, the lips for color. The gums, like I mentioned just a minute ago. Sir, can you please open your mouth? See your gums? Okay. All right. Like I said, you want to make sure there's no gingivitis or anything like that. You're observing the trachea as well. Neck vessels. You're seeing, is there any jugular vein distension? Sternoclavicle. You're checking the clavicle here. Make sure they're symmetrical. Area, you're checking the upper extremities, the lower extremities. Again, we've already went through all the lungs. On the lobes specifically, we're looking on the lobes. We're looking for any kind of crease there on the lobes. Okay. If you might be hard to see that, you can always try and illuminate the lobe. Okay. and that would help give an identification if there's any kinds of crease that maybe you couldn't see it with the naked eye. And in this case, there were no creases. And this gives us a very good indication of the cardiac. It might be a sign of cardiac problem. Now the cardiac is located on the anterior chest. It's located on the left area here. In some rare cases, and I have taken care of a lady before, if you go to listen over here, you don't hear nothing, check over here. In some rare cases, all the internal organs can be reversed. So don't be shocked. Just check the other side first before you make any assumptions that the patient's not alive. Okay, and the heart here is consistent of the right and the left ventricles, the atria, the enteroventricular valves, the semilunar valves. Okay, all right, and there's 4 main areas you're gonna note. That you have the aortic area here, which is just here below, and the second intercostal space right here. Okay, you have the pulmonic area, which is just on the other side of the sternum here, on the second intercostal space. You have Erb's point, which is just one intercostal space down here, usually just in the third intercostal space. And you have the tricuspid area, which would be down here in the fourth intercostal space. And you have the mitral or the apical area, which will be right down here. Okay. Now the anterior chest area here that we're looking on, you have your sternoclavicular, your subesternal, the aortic, like I said, was in the right intercostal space, the pulmonic left intercostal space. This is very important to remember because we're going to have to use this a lot as we're listening. The Erbs, you have the pulmonic, the tricuspid, and the mitral left here. And you can also listen here in the epigastric area as well. Okay, the enteroventricular valves, which is a mitral valve, is the left heart, and the tricuspid valve in the right heart. You have the semilunar valves, which we'll be trying to listen to, will be the aortic, which is on the left heart, and the pulmonic, which is on the right heart. Okay, we're going to take vital signs. So first I'm going to take an apical pulse for 1 full minute. It's very important the first time you hear a patient, you want to listen for a whole full minute. All right, and that would be 88. So we're going to go ahead and make sure we get that down. Now you also want to compare the apical pulse to the radial pulse, so they should be the same. Okay, so which we still have 88 too. That's all right. Now we're also going to go ahead and take a gentleman's blood pressure. If you could just please go ahead and take a seat, sir. We're going to check your blood pressure now. Another key point also, make sure your stethoscope is very clean. What I've also forgot to mention, you're going to mention to the client that, it may be cold, give them a fair warning. Try to warm it up with the alcohol prep before you apply the stethoscope to the skin. Right, sir? Put this on. It may be a little bit cold here. Thank you. And just relax your arm. So you feel a little bit of pressure right now, sir? All right. 128/72. Thank you, sir. All right. Now on the pulse, as we're listening to it, anything less than 60 would have been a bradycardia. Anything over 100 would be tachycardia. And also, when you listen to it, you want to listen with the diaphragm here as well as the bell of the stethoscope. Okay. So now we're also going to listen to it with the bell. Okay, and you continue to do that for a whole minute. The heart sounds are expected are at S1 and S2 are extra. Or extra if you hear S3 or S4, you may hear in the with a pericardial friction rub, heart murmur, or some kind of bruit. S1 is the loudest in the apex. So you have the base, which is here. You have the apex of the heart, which is about here in this area here. So your S1 is loudest at the apex, which is your lub, and the S2 is the loudest at the base, which is your dub. So you should be able to hear a different here. And then your lub louder down here. Okay, and like we said earlier, you want to listen to both. So I'm going to go through each area and listen to them with both the diaphragm and the bell. So again, we're finding the second intercostal space here, just to the side of the sternum. All right, now we're going to listen to the same areas with the bell. All right. The mitral and tricuspid valves closure is best heard at the apex down here. The aortic and pulmonic valves are closer is loudest at the base of this. If you want to listen to the aortic and pulmonic. The systole, which is between S1 and S2, ventricular contracture and closure of the AV valves, the mitral and tricuspid begins with S1 and then ends with the S2, which is the first sound you hear and the second sound, like I said, where we said you're best off to hear them. Distally, which is between the S2 and S1, represents a ventricular relaxation. The closure of the semilunar valve, the aortic and pulmonic, begins with S2 and ends with S1. So like I said, you have to go to the different areas to know where you're going to be able to hear those best. When you're checking for S3 and S4, it's best heard here with the bell. It's a low pitch, quiet in the mitral area. S3, which is a rapid ventricular filling caused by an elastic, stiff ventricles, aka ventricular gallop, is heard right after you hear the S2 in the early dystole, which is it'll be like a lub-dub D. D would be the S3. Okay, and then S4, which is a atrial contraction, is caused by stiff atria, aka atrial gallop. It's heard in the late dystole right after S1, and it's pre-systolic. So it would be like an S4, S1, S2. S4, S1, S2 would be like the D lub-dub, and the other one we had it there at the end. D meaning the S4. And also may be heard while supine. Pericardial friction rub, which is due to inflammation of the pericardial sac, and it resultant roughening of the surfaces. It's a high pitch throughout the chest. It's best heard with the diaphragm, this side here, where while near the apex. So the apex would be down here, where the pericardial comes in contact with the chest wall. All right, and this may be best heard with the client sitting up and leaning forward with the breath held in and expiration. All right, sir, can you please lean forward? Okay, and please go ahead and breathe out. Breathe out deeply. Okay, so obviously we don't hear one here, and like I said, to hear the difference, so you're not hearing a pulmonary friction rub, you can have them hold their breath. It may be an intense grunting or rubbing or scratching, scraping, something like sandpaper. Opening snap, which is an opening of the intraventicular valves, which is not usually heard, occurs in the mitral and tricuspid valve and may be stenotic. An ejection click, also maybe something you might be listening for, which is opening of the semilunar valves, which is not usually heard. It happens in the aortic and pulmonary valve. It may be stiff or deformed, sharp clicking quality, best heard with the diaphragm, with the client sitting in a supine position like he is right now at the aortic base and the second right intercostal space. The pulmonic base, which is in the second left intercostal space right here on the left side. Second, you're gonna remember the clavicle, first one, second one down. So you'd hear best here in this area. Also, while we were listening to the heart and we were listening to the different fields with the bell and diaphragm, we're listening for murmurs. You want to note the murmur timing. When is it heard? Okay, and what part of the lub-dub is it heard? Is it beginning, in between, in the middle, at the end? Is it systole? Is it, like I said, between one? Is it early, late, or mid in the systole? What else? Or is it heard in the dystole between S2 and S1, early, mid, or late? Is it pre-systolic? Okay. So you want to, as you're going through, you want to listen to that. Location, where is it best heard? You always don't want to write that down. If you hear a murmur anywhere, where do I hear it the best? And identify that. You can maybe note that by the intercostal space. Okay, is it in the third? Is it the fourth? The fifth? Is it on the left? Is it on the right? Okay. Radiation, how far can you hear it? Can you hear it from here all the way down to here? Okay, you want to also put that. And you start from the loudest point. Carotid bruit, which may actually be a radiating heart murmur. So maybe if you hear it up here, you may think earlier when you're hearing here, you're hearing a humming, but it's actually a murmur down here. You want to note the pattern. Crescendo, it starts off soft, it grows louder. The crescendo, which starts out loud, becomes softer. Crescendo, discrescendo, or decrescendo, it builds up and then it falls flat. Or a plateau, which is a uniform, which stays the same throughout. Okay, and murmur grading goes into different areas. There's a 1 through 6. 1-6 would be a very faint, may not be heard in all positions. So you got to really listen in when you're doing that. 2-6 is quiet, but heard immediately after placing the stethoscope on the chest. 3-6 will be moderately loud. 4-6 loud, but also have a thrill. 5-6 very loud. You have the thrill, and it may be heard with the stethoscope partly off the chest. 6-6 is a very loud with a thrill, and it may be heard with the stethoscope entirely off the chest. Okay, you also want to note the murmur pitch. Is it high, medium, low? Do you hear it best with the diaphragm or the bell? Murmur quality. Is it a blowing, a rubbing, a musical? Is it a harsh? Okay. So that would be focusing here on the heart. Now we're going to go ahead and go into the peripheral vascular assessment. So just like every system, we're checking the skin. We're noting the color. Is it pink? Is it pale? Is it red, which arrhythmia? Blue, cyanosis? Is there yellow in the skin? It would be a sign of jaundice. Orange, keratonemia, mottling, mosaic, hyperpigmentation. Okay. Is the color the same throughout? Okay, we're looking at the arms and the legs. Is the color the same throughout? So can you please raise your other arm here? Is the color the same throughout on both sides? We're going to check capillary refill first. Sir, can you please hold up your hand here? Capillary refill. You're going to press on each fingernail bed there, and you're going to check for it's going to turn white, and you're going to want to see that redness flash back, and it should be within 3 to 6 seconds. And we're going to do that on each finger. Okay, see your other hand, please, sir. Okay, should be, and you want to note, is it brisk, is it sluggish, and like I said, how long does it take? And it should be less than 3 seconds, if I mentioned that. Okay, now what we're going to do is an Allen test. If you want to please stand up, sir. And let's try to get this here in the camera best. Okay, so on an Allen test, you're going to occlude the radial and ulnar arteries. Okay, sir, so right now I'm going to go ahead and press down here. I'm going to ask you to make a fist. Okay, and then when I tell you to release it, I need you to release the fist. So you're going to go ahead and press on both. Can you please make a fist? Okay, you have them make a fist. Now can you please release the fist? Okay, and then here I let go of the ulnar, and you should see the color return back. Okay, and then you're going to do that again on the other side. Okay, sir, make a fist. Okay, now release that fist. The radial, and you'll see it, the palm here will turn red. It went from a white to a red. That's how long it took there to get back, which should be 3 to 5 seconds. And you're going to do that on both hands. Okay, sir. Can you squeeze your hand up? Okay, let your hand out. Check on the radial. Responds back to red. Okay. Okay, can you squeeze your hand? Okay, now let's extend it out. Okay, and you see that nice red return there once we let off there on the ulnar artery. Okay, next we're going to check pedal refill. Sir, can you please lay down here in this lovely bed here? You lay flat on your back, sir, in a supine position. Okay, with the client laying in a supine position, you're going to have them elevate their legs. So can you please elevate both legs? And you may need to help them with this here. So you're going to leave their legs elevated like this in a supine position. You can have the patient wiggle their feet. Can you wiggle your feet, sir? Just to speed up the process. And while it's lifted, you're trying to get the blood to drain from this area. And then bring the legs down, and we're going to check for pedal refill. Okay, so we're checking the feet here. We're looking to see, we want to see that redness come back. Should take about 10 to 15 seconds. Anything over that, we would be concerned. Okay. You want to observe the nail characteristics on the feet. Okay, the presence of the nails, the color, the shape. Is there any clubbing of these nails here as well? As we did earlier, we could check the Schramroth test here on the fingernails. You want to note the texture of the nails. Are they gnarled? Right now they're here. We're going to check for edema. Okay, check edema here in the leg. Just to press here in the ankle area all throughout the leg. Okay, and if it is present, if it's generalized throughout the body, would be anasarchia. If is it localized, dependent on what parts, where you want to know where exactly that edema is. And the grading is more subjective, but you're going to look at a 1 through 4 scale. 0 would be no edema. +1 would be a mild pitting, maybe 2 millimeters in depth, with a slight indentation. Okay. +2, but that one would disappear rapidly. A +2 would be a moderate, maybe 4 millimeters. Indentation quickly subsides in 10 to 15 seconds. 3 plus, which would be a deep, 6 millimeters, and the indentation persists for 60 seconds. And the area looks full. And then you have the +4, which is very deep, 8 millimeters. And that pitting, when you press in, can last anywhere from 2 to 5 minutes. And the area looks grossly distorted. Okay, you're going to check for hair distribution on the legs. Is there any hair loss to one side, or both the same, the color the same on both sides? You're looking at hair on the toenails. We have hair present here on the toenails. And like I said, you're going to compare each side. You're going to feel temperature. Okay, we should be the same throughout. Hands. Same thing with feet and hands. You're going to check the hair distribution on the hands, the warmth, the skin, the temperature. We're looking for lesions. Just like anytime we're looking at anywhere in the skin, we want to note those lesions. Okay, we're going to note pulsations, noting the rate per minute, the rhythm, check the amplitude. If there's so when we're going to go through and check all his pulses, 0 would be absent, non-palpable. +1 would be diminished, barely palpable. +2 would be expected, appropriate. And then 3 plus would be a full increased. 4 plus would be bounding and can't be obliterated. So now we're going to go ahead and look at the pulses. Okay. So first we have the exterior maxillary pulse, okay, which we're going to check up here. Okay. First we're going to check the temporal pulses. So we're going to remove your glasses for a second, sir. Okay. So you want to note on both sides, noticing any differences on either side. It should be symmetrical, rhythm, rate. Okay. All right. Now we're also going into the carotids. All right, now we're going into the brachial pulses here. Okay. You're always going to check both sides. You want to note that there's a present pulse. Then we're going to go to the radial pulse. And then the ulna. Ulnar. Okay. Both hands. Luckily for me, the gentleman has a very good pulse. Next, we're going to go into the femoral, which is going to be right here in the thigh. Sir, can you please move out your thigh area? Okay, and you want to go under the skin for this demonstration purpose. I'm going to go here above the skin, but you're going to feel in there real deep. You may have to push around a little bit, as well as on both sides. You can ask them to extend their legs, so it provides more privacy for them. Let them know what you're going to do first. So that's how we would check the femoral area. Okay. After that, there's a popliteal, which may be a little bit harder to feel. You can just, cup both fingers in there. Okay. If you have difficulty feeling it like that, you can have can you please turn over on your stomach, sir? You can have the client turn over, and you can just slightly bend the leg up, and then maybe like this, you may be able to feel it a little bit better. Sometimes you might have to be a little bit gentle, push in. You just got to explore in there and feel how you can feel it the best. There we go. All right, sir, can you turn back over? Next, we're going to go into the last two, which is your posterior tibula. Okay, should be just right here in the inside area. Now, these ones, you got to be real gentle. You don't want to press down too hard, or you can obliterate the pulse. Nice, strong. Okay, and then last we have the dorsal pedia. Okay, it's right here on the foot, just going straight down to the big toe. This one as well, you need to be very comfortable. Very softly sometimes so you can feel it. It's not like I said you can obliterate the pulse. Okay. You want to notate the and you want to, like I said earlier, you want to compare contralaterally each side and epislaterally. So from here to here, you know, was there a big difference in the rate, the rhythm, the pulse? Okay. Pulsations, you want to know is the thrill palpable, is the bruit audible, which is a low pitch, and like I said, again, better heard with the bell. So now we're going to go on to the neck vessels, okay, which you have two carotid arteries, okay, you have two jugular veins, two sets, external and internal. You have, and you want to listen to these with both the diaphragm and the bell. Usually it's best heard with the bell, and we're listening for a thrill, a bruit, or a hum. Then we're going to turn over the diaphragm as well. All right, and the carotid, it's in between the sternocleidomastoid and the trachea. It's medial to the sternocleidomastoid muscle, which is going to go right here. That helps you with your neck movement. It might be best, easier to hear if they're up in an upright with the neck flexed towards the side being counted, so you can have them turn away. That can also help you. You can sit them up a little bit more and turn them over. In this case, we don't have a hospital bed. It's not as easy a task. The pulsations, like you want to, like I said earlier, you're going to palpate. Like we checked all the pulses in the lower half of the neck to avoid the sinuses. You don't want to depress both simultaneously. We were, like I said, we were listening, noting if there was a thrill or a bruit. Sorry. The medial end of the clavicle here, okay, and the anterior margin of the sternocleidomastoid, which we're listening for a low pitch, is to have a low pitch. It may be rated cardiac murmur, like I said, like we talked about here. Instead, you're checking the jugular vein. And can you see it in here when they're like this? You sit them up. You can have them sit up earlier, the external jugular, internal jugular. If he's with the hospital, you can just slowly raise it up and see if you can see. You don't want it to see it very distended or pulsating. Oscillations reflect the change within the right atrium, and they may vary with the client's position as they're coming up. Like I said, best if the client's reclined and the head slightly elevated on a pillow, about 15-30 degrees. With the sternocleidomastoid relaxed. In this case, it'd be hard for him not to relax that muscle if he has to use his force to hold it up. Like I said, and it shouldn't be visible upright, and you're going to check bilaterally. You're going to check on both sides here. Okay. And this is not countable. Like I said, it's a vein. It doesn't. It's venous. It doesn't have a pulse. The venous hum that I was listening to, it should be a continuous, louder during distally. It's caused by a high velocity of turbulent blood flow into the jugular vein, but it's best heard over the right subclavicular, so it's over here in this area here, okay? No, right subclavicular, over here in this area, sorry. And it's the medial end of the clavicle, anterior border of the sternocleidomastoid, right here, okay? With the head upright, slightly tilted upward, it will give you the best thing. And it may increase when heard if you turn them away from the area that you're auscultating. If a hum heard, it may be okay, maybe in children, but in this case, we don't want to hear one. We're also going to check the legs for varices, okay? It's best to inspect while standing, sir. Can you go ahead and stand up? Or you can also do a Trendelenburg test. While they're supine, you can have their left leg above the heart until the vein empties. Quickly lower the leg. If it is incompetent, the veins will fill rapidly. Okay, so with them standing here, you're going to be checking the legs, looking for any varices. You're going to palpate those, and is there tender to touch or anything like that? Do they have any discomfort while you're palpating those? Sir, can I have you just lay back down again? Next, we're going to do a Hohmann sign. Okay, so you're gonna extend the knee, apply counter pressure against it. So we're gonna push in here, and we're gonna forcefully dorsiflex the ipsilateral foot, and then you're gonna squeeze here in the back. Do you feel any pain, sir?
No.
Okay. And this sign, if they do feel some pain there, if it's positive, it may be significant of a thrombosis. It doesn't necessarily mean there's one, but we should definitely look into that some more. Also, we're gonna, like I said, holistic beings. We're gonna look into the lymph nodes. We had already did it. We're gonna, continue to check the axillary, central, lateral, pectoral. Okay, we're feeling for any bruises, any discomfort. Keep an eye on the face. Do you see any movement in the face? Okay. The eptoocular, which is going to be located in here between the biceps and the triceps. Okay. Okay, if we notice anything. The inguinal, horizontal, vertical. So we're checking the inguinal area as well. Okay. And we're going to compare those bilaterally. Obviously, if one side feels a little bit harder, rougher, larger, then that might be a problem. And we're going to ask the patient, do you feel any numbness, tingling, burning? No?
No.
Any pain? Have you felt any pain anywhere throughout your body?
No.
Okay. If so, if it's constant, is it intermittent? Is it associated with activity, inactivity, or positioning? Well, thank you, Mr. JR. That completes our assessment for today. Is there any other questions you have?
No, sir. Thank you.
Okay. And that would be it.